Welcome back to BB Uncut, where we talk about health, wellness, and everything in between. Today we have an amazing guest speaker, Tamika. Thank you so much for coming on.
That's okay. Thank you for having me.
You're welcome.
It's really exciting.
So I wanted to have Tamika on today because she helped me with my journey a lot with the kids, like a lot. And I'm going to go into detail about what happened with Sterling and how she helped. But take us through a little bit more about you and what you do.
Okay, that's a big question. I'll go chronologically. I trained as a registered nurse first and then did my midwifery. And so at the moment, I'm currently, as I just said to you, I've got 3 little hats that I'm constantly floating around. So I'm an endorsed private practice midwife. I also am an IBCLC, so International Board Certified Lactation Consultant. That's a lot of words in a sentence.
Important to know that though.
Exactly. And then I also have done some extra study in Orofacial Myology Therapy as well. So it's kind of, I guess it's all connected together, but it's just an extension of that. So
yes, yeah. Take me through how they're all interconnected for people that don't know how that kind of all connects.
Of course. So obviously, I guess midwifery is the base of, or nursing is the base of everything. In terms of an IBCLC, so International Board Certified Lactation Consultant means that there's certain hoops is probably the right word, certain extra training and things that I needed to do on top of my degree as a registered nurse and midwife. And it's basically an international qualification. So it's kind of like a breastfeeding specialist. So obviously it's an extension of knowledge, and then as a IBCLC you can work independently as a basically practicing in infant feeding. And then orofacial myology is basically looking at how all the muscles of the face and the tongue and the mouth all connect together. So that's why it's definitely, for me, when I've been working obviously with little people, so newborns and 4, 6, 8, 10-month-old babies, and obviously the topic that we're going to talk about soon is that the OMT stuff is just kind of an extension. So when you understand function, oral function, then it's across the lifespan. So it's not just babies. So that's how it's all kind of interconnected.
It is so interconnected. So take me through how you got to where you are today and decided to dip your toes in all the areas instead of just doing midwife stuff.
I think I've just always been a super curious person, and it was kind of like I did my mid and I loved that, and then I loved like helping women breastfeed postnatally, and then I was like, I need to learn more. So then that kind of led me to do my IBCLC certification, and honestly, when I reflect back, there were things that, like, it's so funny, one of my exams that I needed to do for my IBCLC course, and I'm talking back in 2007, so it's like a long time ago, I actually just chose tongue tie as a category. Like, it was a random, we could do different assignments. And so I remember kind of it dipped my toes in a little bit, and I started to understand very minutely about tongue tie. And then when I went out into private practice, worked as an IBCLC, I guess I just started seeing more babies that were having oral feeding dysfunction, and then it basically forced me to learn more and dig deeper. And then, I basically, it sounds funny, but learning from, I think as a clinician and a practitioner, the more you do, the more you see, the more you learn. Then you go and do different conferences and you seek out different further education, and then you then have that further understanding that you can then keep continuing on from. And again, like in terms of oral function, yes, I was doing really lots of stuff with babies, and then I was like, hang on a second, this doesn't just stop in infancy. So it's their siblings, it's their 3-year-olds, it's their mum and dad, it's not just... And then again, did further extension of training from that perspective as well.
Yes, okay. Was there anything that you did that really was like an instance that put you in the position where, like, I need to know more, this is just not enough, like this isn't serving me anymore?
I think it was more just when it was literally just the babies. They just kept coming to me, and I was like, they've got ties. Why? And there was nothing else that we could do to fix it. So it was like we tried all the conservative and we tried things, yet they were still having issues. So it was more that when I just kept coming up and seeing these things. And obviously, women were coming to me because they were having feeding difficulties. Like, they weren't just coming for the sake of it.
Yeah,
And
100%.
so obviously the population that I was seeing was biased because it wasn't people who were having great breastfeeding journeys and babies were happy and healthy.
Yeah.
So yeah, I think that's it. It's just these babies kept coming to me and it just kind of made me go, oh my God, I don't know this.
Yes.
And there's not, even today in 2025, there's not a lot of education in any undergrad degree across the health span. Like
there isn't.
There's not.
So take me through a bit more about what tongue and lip ties are, and even cheek ties that happen a little bit as well. And for people, I didn't even know they existed until I was going through my breastfeeding journey and was struggling for a long time.
Yeah.
So take us through what they actually mean and signs of them as well.
Of course. So I think that's a really, this is a really good question because, there's polarizing politics all the time, but it's kind of like, oh, it's just a frenulum. So basically every human has a piece of tissue underneath the lip and underneath the tongue. And we're supposed to have that normal anatomy of having that piece of tissue there.
Yep.
When we're talking about a tongue tie or a lip tie or a cheek tie, what we're talking about is that piece of tissue is inelastic and restrictive of function. So basically, when we have restricted tissue, so I kind of even move away from the words tongue tie, lip tie and call it more oral restriction because I think that categorizes it differently.
Yes.
And so essentially, like, to really keep it very simple, it's kind of like when the body can't move in a normal functional way. So just like if you were born with webbing in between your fingers, yes, you can move your hands and your fingers, but you don't have that full range of motion. So when the tissue underneath the lip and the tongue and the cheeks is restricting that normal oral function of the body, then that is what we classify as a tie.
Yeah.
And I know you asked about symptoms. This is, again, I think one of the reasons why it's so challenging to put this into curriculums across the health span is that when you're learning about oral restriction and function, the symptoms is so broad and it fits so many different bodily systems, and it also is so dependent on the individual child and the baby. So you can have a set of twins who are, same gestation, born to the same mother, usually born by the same method, Caesar vaginal birth, yet they can still have very different symptoms in how they present. So there's so much that can influence presentation. So it can be birth order. So your second baby is unlikely to not be gaining weight well in those first couple of weeks because you've lactated before, so you've had enough milk production. Yeah, so I guess the key ones that are normally, I guess the most common symptoms that I see is usually latch dysfunction in some way. That may be nipple pain, but it may not be nipple pain. Coughing, clicking, choking, spluttering at the breast, struggling with when people say I've got a fast letdown, that's often due to the tongue's inability to function and swallow. Excessively gassy babies, the babies that we call colicky, we say they have reflux, so vomity babies. Yeah. Honestly, there's so many different bodily systems that it impacts. So babies who are sleeping with their mouth open constantly, low forward tongue posture, babies who are struggling to gain weight, but sometimes babies will gain kind of too much weight because they're just constantly feeding all the time because they're trying to get. So when the tongue is not functioning properly in the body, the tongue is not sitting against the roof of the mouth. And so when it sits against the roof of the mouth, it turns on the vagal nerve. So basically we turn on the vagal nerve, and the vagal nerve is responsible for switching our body out of fight or flight and into rest and digest. So when babies have ties and they don't have that nice functional swallow and or that functional pressure or lift through the range of the tongue and into the palate, then they're often the babies who are needing to constantly suck on something. And, the common kind of phrases that I hear that people have said about babies who are tied is like they're a lazy baby, or, they just constantly need to suck on something, or, they're a bright-eyed bushy-tail baby. Like they're the wired babies that are constantly doing these ones, that they're not sleeping, the colic, the reflux, all of those things. And I think it's important to kind of point out that obviously the symptoms that I'm saying are extremely broad. So it's not just about, you can have babies that have had muscular disruption from their labor or their birth journey. So there's other reasons of why babies have those symptoms.
Yeah.
But it's really important to be aware that, if you've got any feeding dysfunction, if babies have shallow latches, if there's pain, if there's, those babies that we can't fix with other simple things,
Yes.
to actually just go and see someone to have an oral functional assessment. So it's not always TICE. Sometimes I work with babies and I'm like, oh mate, you've had a really long labor, you were deflexed OP, you've got a lot of muscle and fascia strain, and that fascia strain is meaning that the mouth isn't working properly, but that doesn't mean that they have a tie. So we release that, we do a couple of different things, and then the babies are functioning and feeding well.
So if they've got that going on, what do you do instead?
So again, it really depends on the baby and the presentation. There's sometimes some at-home exercises that I'll prescribe to parents to do, and really we're just, trying to work to help baby latch and function better at the breast. At-home exercises, I will often talk to parents about working with like a pediatric osteo to help release some of the muscle and fascia strain patterns. And then we're looking at different things to kind of help support that function and correct that function. Yeah.
Awesome. So I'm going to take you guys through Sterling's journey a little bit more and how I found Tamika. So what happened was I actually had Sterling, and when I first had a home birth, I was seeing if he had any tongue or lip touches by our midwife, and they said, oh no, all good, everything's fine, feeding's great, all of that. She's like, okay, cool. Like obviously that was in the back of my head, like that's all fine. Do you know what I mean? Like it's all kind of been ticked off and looked at. And so that was something that was never in the back of my head. And then what happened was some types of symptoms we were struggling with from the get-go for Sterling was silent reflux. So always burping and having lots of vomit come up, like even half the feed from every feed. I could only feed him laying down. He would not accept breast sitting up at all. He'd splutter and choke. He'd also have clicking sounds when he was breastfeeding as well. He had really, really, really big cheeks.
The tight cheeks, yeah.
That's a big sign, I realised, of overdeveloped muscles. Is that right?
Yeah.
So, and like you could feel them, they're so tight in there when you put your finger in there. So they're the types of symptoms that we had for Sterling, and I was struggling for 4 months and like he wouldn't fall asleep unless he was rocked to sleep, like quite rough as well, like always wanting to feed constantly 24/7, always crying, always screaming. Like we just had so much trouble with him. And so what I did is I saw Tamika, and do you still remember Sterling's case?
Kind of, but there's probably been.
No, it's so fun. So when we saw Tamika, she essentially said, oh my God, she'd put her gloves on and she did some like feeling around in his mouth and found that he had tongue and lip ties.
Yep.
And he was 4.5 months old at this point, which is obviously like he's quite older. But the reason I didn't worry too much earlier on is because he was gaining weight. He was like 170th percentile, so big for his weight in size 6 to 9 month clothing at 4 months. So he was very, very big. But again, that's a sign that it can sometimes be tongue and lip ties. He was just feed ties. He was just feeding constantly. And so essentially we went down that tongue and lip tie process of looking at getting it released and seeing an osteopath or whatnot. But take us through going back to that. If you are having someone that's positive with tongue and lip ties, what are the stages of treatment and where do you go from there?
Okay, so this is, something that I talk about with families all the time is that essentially when I see them, what I'm doing is an oral function feeding exam. So I think it's really important to have the baseline and go, okay, this is what I'm seeing. This is how baby's mouth is working. This is how they're compensating. And these are symptoms that can correlate. From there, I always talk about conservative management and then also treatment approaches, because I really believe that, I can't make a decision for families about what they're choosing to do.
Yep.
So conservative management is still not fixing the root cause of the problem because we're still going to have the restricted tissue.
Yep.
But there's certainly things that we can be doing to be supportive therapies that can help babies function a little bit better. So things like body work, at-home exercises, correcting latch function, supporting milk production, supporting microbiome with, again, so you know how you mentioned with Sterling, like the clicking and the coughing and the choking and things like that. So that meant that he was taking air into his gut. So his microbiome was not probably very happy.
Yeah.
And in those instances, then normally I'll get mum to take a good quality probiotic so that we're supporting that kind of function.
Yeah.
And we need to kind of be aware and mindful of what happens with milk production. So, you know, the first 3 months of babies' lives is very much driven by hormonal support. That's from birth. So what often happens is that babies will be gaining weight well, and then at 3 months they're not gaining weight well.
Yeah.
Because as those hormones drop off, and then your body has to be solely reliant on milk removal equals milk being made. And that's where, like, you know, for Sterling, you've had a baby before, you've lactated before. And so he was a big, happy, healthy baby. But he was feeding constantly because he wasn't getting any vagal nerve
every
contact.
2 hours.
That's exactly right. So that's why we have to be very aware and look at the circumstances around why babies are feeding so frequently.
Yeah.
Again, I'm not saying that babies feeding frequently is wrong, but in the instance with Sterling, we knew why he was doing that, and it was to constantly get that activation on his palate because his tongue could never get there. Yeah. And then so we look at supporting milk production. We look at what we can do to cushion all of those different things. So whether it's sometimes magnesium in the bath to help with nervous system, sleeping, settling, doing all those different things. So I always say that when we go down a conservative management pathway, it's being conscious that we might see symptom improvement, but we see symptom improvement because we're doing all the things. When you stop all the things, we still have the ties that are remaining.
Yes.
And then if we're talking about a treatment approach, I never recommend that we rush in and do a procedure without doing all of these things first. So I think it's really important to have that awareness that we can't just be like, baby's got a tie, let's go and book them in for treatment in 2 days' time, because their body's not going to be ready. Their nervous system's not going to be ready. We want to unwind all that muscle and fascia strain that they've had either from the birth journeys or that they've built up because of their strains and stresses. And then how we can actually release tissue is there's 2 different methods. So there's scissors and there's laser. And again, I kind of always say to my patients that it's very dependent on the tissue typing, the age of the baby, the skill of the provider. So again, there's lots of talk about one method being better than the other or vice versa. And basically my kind of rule of thumb is basically the tool is only as good as the person who's using the tool. Yeah. But we also have to have the right conditions and the right tissue type. So sometimes I see babies and they might be really struggling to latch. They've got this thin tie that's right to the tip of the tongue. And I'm like, okay, they might be a really good candidate for scissors at this point. Yeah. But if we needed to treat something further, or if it was a really thick or fibrous tissue, then scissors may not be the instrument of choice at that time. But yeah.
Yep. Yes. So when we started treatment, what we did is we actually did the laser. And it wasn't the laser that we noticed an immediate improvement on. It was when we went to the pediatric osteopath and actually worked on the overdeveloped muscles so that he could then feed properly. The overdeveloped muscles were coming from the ties that were there.
Totally.
Correct?
Yeah. And that's where the OMT comes in. So basically when your tongue isn't moving properly, your body recruits different muscles. And so in Sterling, it was his cheeks. So because the tongue wasn't moving properly, he was really recruiting these cheeks and chomping.
Yes.
Yeah. Yes. Which causes the nipple pain.
Yes. Yeah. So we had absolutely life-changing results. I could breastfeed anywhere, any place, didn't have any issues with him feeding after we had 2 appointments with the osteopath within 7 days post-laser treatment. So obviously looking at that root cause for his feeding issues was the ties, but we then needed to address the other factors that then were also impacting the feeding because of the ties itself, which was the overdeveloped muscles. Absolutely, honestly, he was a different child after it, which is why I wanted to spread some awareness about the issues that come with breastfeeding and how it then goes into adulthood if not treated as well. So going on that, take us through ties and a bit more about those symptoms and links to adulthood and as we grow up as teenagers.
This is
I know you can talk.
Can talk
30 minutes if you want. It's fine.
No, it's so fine. basically, I kind of, I talk in bodily systems because we know that, again, the tongue is such a vital role in our whole body's kind of our posture, our structure, our swallow, our digestion, airway, jaw growth, palate development. So essentially, it is very much across the lifespan. And as I said before, that every baby and then every person, if they have restricted tissue, they're actually, they're all compensating differently. Does that make sense? So depending on so much variability, so muscle tone, how they're compensating, so many things is going to vary the presentation of symptoms. But basically, the ways that we know are medically documented. So there was a study recently published, I think it was either last year or the year before, my years are gone, and it was looking at the outcomes of like 5-year-olds who hadn't treated ties. And basically the areas that they concluded that they were impacted were things like speech, so not necessarily not being able to speak, but articulation sounds, eating, so your fussy eater, your child that won't eat harder foods and they kind of go to the softer foods and things like that. So the restriction of the tongue can stop that inability to bite, chew and swallow properly. Digestion is a huge one. So again, that we need that really good functional swallow of the tongue to create that peristaltic action through the esophagus and then move the way through the gut, right? And so without that, then we have sluggish digestion. And then probably a lot of other things follow on from that in terms of, gut health and how the body's absorbing different minerals and nutrients and microbiome
and all of that.
and all of those things. Jaw growth, palate development is a very, again, if that tongue is not working properly, we're over engaging different muscles, which is going to really shape and change the palate. And then when we have high arch palates, if we think structurally, the roof of your mouth is the floor of your sinuses. So your sinuses can't drain properly, your ears can't drain properly. We often end up with that maladaptive, open mouth posture, low forward tongue posture, long kind of face, this narrow face. So it's kind of something that I can kind of walk through a shopping center and I can see what's going on in people's mouths because of how their jaw has grown. Again, if we think about how many people have orthodontics or need to have their teeth taken out because they're not chewing and biting correctly. How many kids have swollen tonsils and adenoids because they're, there's obviously it's multifactorial, but if we are chronically air breathing, if we're chronically mouth breathing, we're not getting that correct concentration of oxygen, carbon dioxide and nitrous oxide that is produced when we're nose breathing. So, microbiome and, our immune system is going to be impacted by not being able to breathe properly through our nose because that's how we're designed to function as humans. Poor sleep, irritability.
Yes, poor sleep's a big one.
Poor sleep's a huge one. Irritability and even things like behavior stuff. So if we're talking about older kids, there's research papers that are out there talking about sleep disorder breathing and ADHD and autism and hyperactivity and all of those things. And, when we do some sleep studies on those kiddos, sometimes it's just that their brain is not getting the right oxygenation. So they might be sleeping, but they're not getting the right quality of sleep because they're not breathing properly. Musculoskeletal stuff, so gross motor, crawling, walking, talking. Posture is a huge one. So what often happens is when people have ties, they develop that open mouth posture, this forward head posture, anterior pelvic tilt. We often get lots of migraines, head and neck tension, TMJ, jaw pain. I feel like how much more? So from a posture perspective, everything. Digestion, so reflux, constipation, sluggish digestion, migraines, headache. It's a lot.
Yeah.
It's an
So
elephant in the room.
if they're noticing that their kids are breathing through their mouth,
Mouth.
that would probably be the biggest sign to then think that those symptoms might be coming from that.
Potentially, or we need to look at why the child is mouth breathing. So yes, it can be ties, that the tongue literally can't get into the roof of the mouth, but a lot of it can be like habits of stuff. So a child that was constantly, again, breastfeeding incorrectly, bottle feeding incorrectly, prolonged dummy use, not chewing when we start introducing solids and things like that. It's a huge one. And I think also in our society at the moment, a lot of kids aren't being offered foods that they're biting and chewing. Obviously, we're getting super busy, and it's really hard if your child is struggling to chew, bite, chew, swallow, to then continue to offer them those foods, because you're just going to offer them whatever is easiest and convenient and what they're going to take.
Yes.
Yeah,
they get to that point where it's just exhausting.
Totally.
Yeah.
So it's not a
yes. Something that doesn't get talked about much anymore is dummy use and what it links to. So do you mind chatting a bit more about what dummies are linked to with long-term use and what you classify as long-term use?
Totally. Any time is long time. Sorry. No. Again, when you understand anatomy and how the tongue is supposed to work, anything that you're putting in your baby, child, toddler's mouth, that is actually going to create a low tongue posture. So that's bottles, dummies, thumb, same. It's going to then activate those muscles that Sterling was using that came from the tongue tie. But that's also why, I mentioned before that sometimes I see children at the age of 2 or 3 and they have kind of symptoms of oral dysfunction and tongue tie, and then I look at them and I'm like, no, they just have been using a dummy for 18 months or and so therefore their body is acting like they've got restricted tissue, but they actually don't. So there's things that we implement to change all of that processing.
Yes, yeah. And so how do you avoid giving dummies if a kid's wanting it for
Again, this is kind of it's a hard one, and it's kind of like chicken or egg. Does that make sense? So I think when a baby is functioning and breastfeeding well, there's usually a limited need for a dummy because the baby will be doing what nature designed. So we know that dummies, pacifiers, they were designed to be a replacement breast, right? That was its general ideology. So it's kind of like when babies are latched and functioning and feeding well, they don't actually have a need for a dummy because the tongue is doing what it's supposed to do and they're getting the satiation from breastfeeding. And so in saying that though, if people are using a dummy to space out feeds or sometimes it's a convenience thing, it's kind of like, but then on the flip side, it's like if your baby is constantly needing that palate stimulation, then we've got to ask the question of why. I think it's really hard when babies are not hard, but hard to avoid when babies are bottle feeding because they also don't get that same satiation and sucking time that they do when they're breastfeeding as well. So sometimes those babies do need that extra stimulation. So again, in those cases, it's like looking for a flatter and broader dummy that's not going to like fully fill that mouth cavity and using things consciously. So it's kind of like, sometimes I've got mums come in and they're at the wit's end because their baby's so unsettled and they're constantly needing to suck, and it's kind of like there has to be a happy medium. So of course there's optimal but then there's also real life, and that's where it's really difficult. So it's kind of like if you're using it consciously, and then once baby's asleep, taking it out and trying to get the tongue up into the palate. So there's things that we can do to make it less damaging, I guess, than what would happen.
So one of those ways to make it less damaging would be not having it while they're sleeping once they've kind of fallen asleep.
Totally. And trying to after six months, maybe 8 months, like trying to really minimize dummy use as much as we can, like the earlier we can. So it's also incorporating, when babies are starting to like move on to solids, it's giving them different things that they're mouthing and biting and chewing and getting that really good chewing action. And again, if they're sleeping, like let them get to sleep, take it out and not keep it in there all night, those types of things.
especially with over all night, it makes such a big difference.
Totally.
It's like half their life.
Totally.
Sleeping at that age. Yeah. And what I was going to say is, what is one of the things that you find most frustrating with what you do every day?
How long do we have? No. I think the frustrating thing for me, and I think we kind of touched on it before, is it honestly breaks my heart how many women have, they're experiencing, or let's just say families, because the impact on the family unit is huge. Yep. It's not just mum, it's mum, baby, siblings, dad, relationships between every which way. Yep. And so I think one of my biggest bugbears is, I've got a couple. One of them is when health professionals aren't really trained to identify ties, but they look anyway, and they'll tell women that they don't have ties.
That is the most frustrating, because I think that if I wasn't told that Sterling didn't have a tongue or lip tie, then I would have went and got looked at a lot sooner.
Exactly.
So I think that unless you've got like certification to actually know how to look properly, then don't just have a little quick look.
Correct.
So just think, oh yeah, no, it looks fine. It's not like a really obvious tie.
Yeah. So I think that's one of the biggest things, is it's kind of like, it's okay that health professionals don't know about this stuff because there's no undergrad training on it.
Yeah.
But I think one of the biggest disservices that we can be doing to families is, kind of having a look and then saying there's no tie, and then they don't have the knowledge and education to actually do a proper functional assessment. Yeah.
So
that's one thing. The other thing I think is just the amount of misinformation that's out there and the amount of Band-Aid approaches that we're given. So it's like, it's a fast letdown, or it's reflux, or it's CMPI, or it's this, or it's that. And a lot of people are giving that information without actually doing a proper functional assessment, or doing any assessment really. And, the other thing is, I've seen so many women who were told that it was an allergy, and then they put on hypoallergenic formula, and then they stop breastfeeding.
How do they know it's not an allergy problem unless you're doing an
That's exactly
first?
right. And sorry.
Even with the women and babies we see in the clinic, we've got like allergies or colic or reflux, we always say, have we actually done an assessment to see if there's anything functional going on first? Because we don't want to go recolonize that microbiome or make sure that there's no imbalances there causing the colic, because colic is linked to microbiome dysbiosis, unless we've actually looked at that functional element as well, which
Totally.
I think, it's definitely something that's missed too much.
Oh, 100%. And I think it's very easy to Band-Aid those things instead of, and it, like, honestly, it gives me, the kicker is, so stop breastfeeding, go on hypoallergenic formula. But the hypoallergenic formula has cow's milk protein in it. But we just tell you that you've got CMPI. Make that make sense.
Yeah. So with the women that you have that have been told they've got CMPI, what are you noticing when you're really looking at the root?
The majority of the babies don't have CMPI. So
that's so frustrating.
Yeah. So, and again, how we know that is that, and I'm not saying sometimes babies are reacting to the cow's milk protein. I'm not saying that they're not, but they're reacting because of, as you said, a different cause. So they're reacting because they're not swallowing properly. They're taking in air. It's causing that dysbiosis. And then the body is then more inflammatory, and so is reacting to the protein, because cow's milk is a larger protein and the body can't digest and process it, right? But again, we should know whether that's actually a cause or not really within 6 hours of a mum can not have dairy for 6 hours, and does baby get better? Yes, no. But again, it's usually coming from function. So swallow function, digestive function, latch function. So again, if a baby's constantly clicking or gulping and taking in air, then of course they're not going to be functioning and feeding well. So of course they're going to have reflux symptoms. It just kind of adds on top of that. And again, the mucus in the stools is the big one. Okay. So it often almost gets like an automatic diagnosis, but the reality is that the reason why we have inflammation and why we have mucus in the stool is from exposure to formula or antibiotics. And let's face it, so many women are actually having antibiotics during labour or postpartum. And then air is a big one. And again, lack of functional swallow function. There's actually lots of evidence and data to support that. So when we're not swallowing and not getting that good digestion, then our body's releasing different things in the bowel and the gut, and it creates an inflammatory environment that produces mucus. So yeah.
So if you've had a woman with a child that's come in, they've done the tie, the tongue tie, they've done a tongue tie, they've done osteopathy work, and they're still having symptoms, where would you go to then?
It really depends on what, like, so it's kind of it's a big picture approach, and it has to look at multiple different things. So we're looking at supporting nervous system, we're looking at feeding function. It's very rare that we kind of do it all in nice optimal timing and we don't start to see improvements afterwards. You know, of course there are definitely those babies who are truly reacting to certain foods. But again, we can carefully navigate that and not be cutting out 20 foods at once, which is the most Yes, I find that when we come in and they've cut out so many foods which could have been avoided, and a lot of times it's that microbiome diversity that needs to be rebalanced to then not actually be triggering to the foods. And it's actually, we need to fix mum. It's not just, we can't be looking at one, like just the baby. We have to be looking at them as a dyad, and it's about repopulating mum's microbiome. Like that's so huge. We actually have microbiome that transfers in the placenta from 20 weeks onwards, and then also in the breast milk. And so skin. And skin to skin. So it's really, really important to make sure that you're looking at yourself as well. So when we have babies that come to the clinic, if you're breastfeeding, a lot of times we'll be working on you as well to then help with colonization from mum. Because if you're really not addressing mum's approach, but then you're giving bubs probiotics, a lot of times that's not really going to hit that root approach because you're still getting it from mum. And exposure. And also I find giving probiotics directly to baby, they get more of like a die-off effect. And so it's like if we give it to mum and it's going through her breast milk, it's usually tolerated. And usually mum, like, you know, mum's microbiome is normally totally out of whack for so many different reasons. Well, if you think about it, we're really seeing the first type of generation that's really had a lot of antibiotic usage, but then is then going on to have kids. So these children are really the first that are going to have this microbiome dysbiosis from the get-go, which is what we're seeing a lot in the clinic. I've only ever tested 3 children that don't have microbiome dysbiosis, unfortunately, ever. We see 1,000 children every year. And so it's really quite a problem that we are facing due to that antibiotic exposure that was then introduced to us, and now we're having kids. So we're really the first that are seeing it. And we're also, like, on the epigenetics, if we think about, you know, our grandparents, for example, and what they were exposed to during their pregnancies, and things like the industrialization of childbirth. So we've been immediately clamping and cutting cords. We've been not breastfeeding for about the 3rd, 4th, 5th generation is coming through now, and we're really seeing the effects of that. And then also, you know, we've had different viruses and things that pop around. We've got, and, you know, I feel like it's kind of like this epidemic of, you know, we've got adults and their parents who have lived with ties, and then they've been chronically mouth breathing. Like it's this kind of ladder of just so much disruption. 100%. What's one piece of advice you wish all mothers had going into this journey? Oh, that's a good one. I think the one piece of advice is just don't take one person's answer as gospel, as listen to your gut and feel what feels right. So totally, because that's the number one thing that I have. My mums will sit in the clinic or wherever I'm seeing them, and they will say to me, they're like, I knew something was wrong. That is like the number one thing. I knew something was wrong with my baby, and thank you for finding out the answer. So yeah, it's okay to get different opinions. It's not saying that the clinician's a bad person. It just means that they don't have the level of knowledge that they need for your baby. And it's not, you know, there's no one here like throwing knives at anyone, but it's just kind of having that knowledge and understanding that, you know, things like oral function, ties, gut health is not something that is widely taught and educated about. So it's just really listening to your intuition and your gut, and if it doesn't feel right, go and find someone else and get a 2nd, 3rd, 4th, 5th opinion. Definitely. Or 15th sometimes. 100. Is there anyone in particular you recommend at the moment to support with laser and tongue releases? Do you have a database of people that you really like? Yeah, darling, I do. there's certainly different providers, but again, I think I don't want to kind of give a blanket rule because it really depends on, as I said before, it's looking at the baby or the child or their circumstance and looking at tissue specific and things like that. But there is certainly different providers. We're kind of quite lucky that we have people in Southeast Queensland, but there's literally only a handful of providers Australia-wide that I recommend. So it's not a huge list to choose from, but we do have a handful
as well.
They do. I know. It's so
really hard,
crazy.
But you want to make sure you're going to the right person. So I wanted to talk a bit more about breastfeeding and why every journey is so different. So with Indiana, I was like, oh, breastfeeding was so easy. It was like just so seamless and it felt so natural and we never had any issues. Then I had Sterling and it was obviously something I did not expect at all to have problems with breastfeeding when I've done it before. Like, what the hell?
Yeah.
Take us through why each journey is so different for breastfeeding.
Oh gosh, there's so many different. Each time that you are pregnant and you lactate, you've laid down different milk receptors and you have different milk production and you have different birth journeys. We have different gestations. We have different babies. We have different functions. So obviously Sterling, he was a boy. He has higher muscle tone and he had oral dysfunction. So, your milk production might have been okay for Indy, but then because you breastfed her, then it kind of was a little bit plentiful for Sterling.
Yeah.
And it wouldn't have been if he was able to regulate and work out your milk production in that first week or two post-birth. Yeah. But because he did have ties and he was a high muscle tone baby and he had all of those things at play, it meant that feeding was a lot more challenging for you. Yes. So, it's very much individual on the baby, the age, their muscle tone, their sex, the temperament of the baby. Like, there's so many different things that come into play.
It's just crazy because I felt like I was like, why am I struggling with this when I literally did it so easily? And I think it just goes to show it's not about the mother and her perseverance.
Of course not.
Which is something that's frustrating so much. Like, I know a lot of older generation women will be like, oh, she just didn't try hard enough. That's so frustrating to me and it makes me so angry.
Totally.
I think that if you're struggling with breastfeeding, it isn't normal to struggle. It's because something's going on. It's very common to struggle, but it means that you need to look further and deeper into why you're struggling in the breastfeeding journey instead of it just being like, oh, that's okay. Totally. I tried everything I could. Keep looking for answers until you get them, because I felt like I was going to give up with Sterling and I'm so glad I didn't, because it became really easy and became seamless once I looked at the root causes.
Totally. And that's one of the things that, it literally breaks my heart, because like, women are told that it's normal to be like painful and I just have to get through, and it's normal to hurt at the beginning, or it's just a fast letdown, or it's this or it's that. So there's so much like gaslighting that's coming from health professionals, from family, from every which way. And then we also have, we have a huge formula industry that has really good marketing campaigns as well, that's going to undermine our ideology and our thoughts as a mother and whether we're doing the right thing for our baby. So
isn't it crazy? One thing I realized is it's illegal for them to do ads on formula. So they just do it all on toddler milk.
Up to 12 months. Yeah, that's exactly right.
So they just do all the ads on 12 months onwards toddler milk, and then we see all those ads when we're breastfeeding instead. So it completely defeats the purpose of what Australia's government was trying to provide. But it's really nice that they did attempt that, because I feel like when you're in the depths of motherhood and you're struggling and then you see an ad, you're like, fuck this, I'll just go into formula. Like, it honestly is the last thing that should be encouraged. I think looking at those root causes is really needed, and seeing what's actually causing it is something that not many people look at. It's so frustrating. And like, I'll have mothers that come in, oh yeah, I just got a really, really fast letdown. I'm like, no, you don't. I promise you don't. It's something else.
And I think it's really, I would say over 50% of my women are worried that they're making enough milk for their babies, but they totally are, and again, like, social media is a double-edged sword, but I think there's so much vulnerability for new mothers at this time and space. And, any kind of programs or platforms that are sold as a one-size-fits-all approach, I think is really damaging, and it's preying on their vulnerability to, that be the golden ticket to help them. And I think it's very much a fine line.
Yes. I I definitely agree with that. And it's like, why struggle? We're told that like there's always meant to be some type of struggle in motherhood. Like, get extra support if you're really struggling. There's nothing wrong with getting a nanny. There's nothing wrong with if you have a really fast letdown. Well, is that actually what's wrong? Go look at actually what's going on. There's no need to actually struggle. We set women up to have the expectation of struggling.
And that they just fix it all themselves, and then if they don't, they're a failure. And it's like, no, we need so much knowledge and support to be able to do all these things. But yeah.
Would you say that when you're noticing women with low milk supply, what are the causative factors that you're finding there?
So most of the time it isn't a low milk supply.
Wow, crazy.
Crazy that. It's almost like our bodies are designed to keep us alive, you know? No, but when there is a true a baby that's not gaining well, that's probably the different language. It's normally just due to latch function and transfer. So it's very rarely that the mum's body doesn't have capacity to make enough milk for their baby.
Yeah.
There is certainly a small percentage of women that don't have enough tissue in their breast to actually produce breast capacity for their babies.
Yep.
But I'm probably talking, I don't have enough, they say kind of less than 3%, but it's really hard to get good, accurate data.
Yeah.
So true insufficient glandular tissue is not something that we see very often, but I do see it occasionally. Obviously, if we've had breast surgery where we've removed the nipple and cut through nerves and things like that, that's obviously going to impact the messages that the brain's getting. And the other one is those mums who've had a lot of separation, at those birth kind of days and haven't laid down foundations for milk production. But most of the time, mums do have the capacity, and it's something that I see all the time. It's like the babies were gaining weight okay for the first 4 weeks or 6 weeks, and then suddenly they don't. But then we're like, it's my milk production. So the most common time for that milk production to kind of start dropping off is anywhere between 6 and 12 weeks postpartum. Yeah. So many women are like 3 months, 3.5 months. Oh, my milk supply just dried up. Right. When babies are functionally well and are efficiently removing milk from the breast, that doesn't happen. Yeah. So it's normally secondary or late onset decreased milk production because baby's not latching and feeding. And again, that gaslighting of, oh, I've got so much milk, fast letdown, I'm only feeding baby one side per feed, and then they get to 8 or 10 weeks, and then what happens to the baby? They're arching their back, their poos stop, their weight gain stops, they wake more frequently, they get really fussy and annoyed at the breast because what happens to milk production? Slow down significantly.
Yes. Yeah. What are the good signs of a latch?
So when a baby's latch, what you're wanting to see is that baby's head is extended. So you don't want to see baby's chin to their chest. So head extended, that the baby's nice and comfortable, that there's actually not a lot of external noises. So we're not seeing or hearing babies coughing, spluttering, gulping, all of those things. Any clicking, so that's a huge one, huge red flag for saying we don't have good vacuum and seal. So you want to see baby's head extended, cheeks touching the breast, nose nice and clear, and that they're not really overactivating these muscles. So when a baby's latched well, their tongue is supposed to be working independently from the floor of the mouth, and it's hard at this point with my hand, but basically the tongue is supposed to lift and fall through the midsection of the tongue to generate vacuum and seal in the mouth cavity. So it's when the baby can't generate vacuum and seal that they then recruit different muscles. So again, if you see dimpling in through here, or you might find baby kind of pops on for a little bit and then pops off again, or they might kind of, it's like they get on the breast and they gulp, 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 and then it's like they're so tired and they fatigue and they're done. So a good latch is a baby who's nice and comfortable, they're not noisy. You can hear swallowing, so you can kind of hear a little sound, like totally, very much a and basically the baby should be really calm at the breast. So when babies latch well, you see them kind of relax into the body and they do like some quick active sucks, and then you can see that milk transfer happen, and then they might go into a flutter suck again, and then they'll get another let down, or milk will flow more, and they have nice active drinking. And then usually they'll pull themselves off that side when they're ready, and then often change their nappy and offer the other breast.
Yes.
But yeah, that's kind of, does that answer the question?
Yes, yeah, and that brings me back to Sterling. So one of the things is he'd have a nap, he'd wake up from a nap, he'd go for a feed, and then he'd fall back asleep on the breast, even though he'd literally just napped, because
Really
he's so
quickly.
exhausted from overworking all the muscles because of the tongue and lip tie that was impacting him to actually swallow and breastfeed properly.
Yeah, definitely.
Which is crazy. all the signs. So they're the signs to look out for if you're noticing that your bubs might be struggling with tongue and lip ties, or any other types of issues that could be impacting breast milk as well. So thank you for that. One thing is, I do often have mothers come in and they say that they don't feel like, they're always worried about not getting enough milk.
Yeah.
So what are signs that your baby is getting enough milk? Because
Sure.
I find sometimes they're pumping, but they're not getting the same amount that they think that they are getting when they're actually feeding. So take us through why that happens as well.
Yeah. So again, it's all coming back down to latch function, of course. But the things that you're looking for, like, again, I say this all the time, and it's, this is not rocket science, right? So basically what goes in has to come out. Yeah.
Yep.
And the amount that a mum can pump at any time is not an indication of how much milk the baby can take. That's a huge thing. But the signs to look for is baby having adequate output? So are we getting 5 to 6 wet nappies in a 24-hour window? Is baby doing a poo a day? If baby is doing those things, they're quiet and they're happy when they're feeding. And don't get me wrong, I'm not expecting babies to just be this perfect little, they feed, they sleep. But most babies who are functioning and feeding well are happy most of the time, and they're easy to settle, whether that's cuddle to sleep in the carrier, all of those kind of normal newborn things. But it doesn't mean baby's just going to lie down and then be happy there. But a baby who's quite happy and they're not crying constantly or struggling to be settled, that's a baby that you can kind of be pretty much rest assured. So you can see that they're doing nice active drinking and swallowing at the breast. They've got good output. They're reasonably happy and calm 85% of the time. Of course, babies are human. They're going to have different different times of the day where, they might be unsettled or they might be grumpy. But as a general, like, it's very different, those mums who come to me and they're like, my baby's never settled, and it takes so much to help calm and settle them. Yeah. And then when babies are feeding and functioning well, they're like, oh, yeah, you can tell the difference between this baby that's kind of calm and relaxed. So poos are one of the biggest indications that baby's getting enough milk. Yeah. So if baby's pooing daily, you can pretty much be rest assured that baby's getting enough milk. Yeah,
it's a good way of looking at it.
On the flip side, not pooing doesn't always mean that baby's not getting enough milk. Yeah. And that's where it's really hard. So if baby is not pooing frequently, and again, obviously we're probably looking at this, the same problem from different angles, but probably similar. Lack of stooling, if baby is getting enough milk, is usually from dysbiosis of the gut. Yes. So air, formula, antibiotics. Yes. And then function. So if we don't get a functional swallow, then we've got sluggish digestion. Yes. So that's why it's kind of easy to troubleshoot, because it's like, if we know baby is getting enough milk and they're gaining well, then if they're not pooing daily, then that's a red flag for what else is going on in the gut. Yeah.
And another thing to keep in mind is, just because you didn't have antibiotics in pregnancy or breastfeeding doesn't mean it's not a dysbiosis, because again, you could have already set up bad foundations from your microbiome dysbiosis that's then traveled on even without the use of antibiotics as well. So it doesn't automatically rule that out either.
Totally. But obviously, if you do have antibiotics during your labor, birth, and post, and honestly, the amount of antibiotic use at the moment in maternity care is wild.
It's actually crazy.
It's so wild.
Yep. And we're forgetting that it's actually negative outcomes to use of antibiotics as well.
Totally.
The health professionals are forgetting that. So I think it's good to remember to make sure you're always using a good type of probiotic that's actually going to recolonize properly. So thinking about something like a Bioceuticals Ultrabiotic 45, or going on to like an SB first, to make sure that there's actually room in that stomach for that good bacteria to colonize. In regards to one more question, I promise I'll finish up soon. But if you're noticing that a mum is really struggling with that breastfeeding journey because they haven't had those foundations set up from the get-go, like they've been C-section birth or they've had a really complicated birth, how would you get them to get onto a good track after that?
The biggest one is get back to basics really quickly. So skin to skin, frequent milk removal. It's not like if a baby struggles or mum struggles in that first week, it's not like, we've lost we've lost our way. I feel like there's always room to make improvement with milk production and milk transfer and things like that. But one of the biggest things is just going back to basics. So lots of skin to skin with baby, getting those nice hormones going through your body, and really frequent milk removal, and being aware that if baby is struggling to latch, we do need to do something to make sure that we are removing milk efficiently, rather than just going, oh, baby's just fatiguing and falling asleep, so oh well. Like, it's kind of it's having that awareness that, okay, baby's not latching properly, so what do we need to do to make sure we are counteracting that, to make sure that the body is getting the messages that it receives. So
100%. What would you say is the most rewarding part of your job?
Honestly, it's so satisfying, I guess, seeing families who have come to me in a state of despair, and then being able to, find what's going on and helping fix and having a completely different outcome. So it's pretty cool.
Yeah, it's very life-changing. I still remember when I came and saw you. And besides that, is there one particular treatment outcome that you still remember to this day that was just really life-changing for you, where you helped a family?
I did have a little baby last year, and I know she'd be very happy for me to share a story because her mum shares it all the time. The mum shares it all the time. This little baby actually ended up with a nasogastric feeding tube. So basically she started with fussy feeding and then was told she had an allergy, so stopped breastfeeding, tried a hypoallergenic formula. She got to the point where she wasn't tolerating suck feeds and she was only taking small volumes despite multiple different hypoallergenic formulas. And she'd actually seen an IBCLC, she'd seen a GP, she'd seen multiple different people on this pathway, and basically baby wasn't feeding, so they had a nasogastric feeding tube. And she was referred to me, and at that point I think she was 10 or 11 weeks old, so she hadn't actually had suck feed. Like, she couldn't tolerate anything in her mouth, as in couldn't transfer any milk from a bottle, for like 5 weeks. So it was crazy. And basically I did an assessment. She had ties. No one had looked and checked. So
Are you joking?
No, I'm not joking.
But there was another lactation?
There was. And there was speech therapy, and there was feeding teams, and there was all sorts of stuff. And I think the day before she had her tie release done, she actually saw the feeding team and slightly mentioned ties, and they basically scoffed at her and said, oh, even if baby does have a tie, then it's not going to change anything now. So again, the amount of gaslighting there is just wild.
That's so upsetting.
So basically, my aim was we had to release a lot of muscle and fascia strain for this baby. And ideally I wanted to get her doing some type of suck feeds, because I was like, it's very hard to go from tie release and suck feeds if we haven't been doing anything, but also time frame. It's been 5 weeks. So it was all about creating positive association and letting her, doing all like what we could. She had frequent osteo. There was a few different things that we played and changed with. And then she had a tie release, and straight after the tie release, she drank 70 mils from a bottle. And within a week later, the feeding tube was out.
That's amazing. What did the team say then?
They didn't have any words.
That's so
but it still wasn't a tongue tie.
That's amazing for you, though. That's so amazing. I bet you felt so good from that. You've changed the whole trajectory of life.
But it just, again, it breaks my heart because mum stopped breastfeeding. There was a lot of other stuff that went on with that, lots of family dynamic stuff that went on with that. And, it basically created so much distress and trauma for that family. And it literally was as simple as baby had ties, that once we fixed them, it got her functionally feeding
Yes.
again. And then now, I love seeing her little updates, and she's over 1 now, and she's eating solids well, she's sleeping well, she's happy, she's just,
Which are
so
all
it's
good
pretty cool.
markers. Yes.
Definitely.
And so when you've got adults that are coming in with myofunctional issues, what are you doing for treatment? Are you either going to release like tongue and lip ties, or is it too past that point?
No, so it's usually like the parents of the babies who I've been treating that I will kind of help navigate that way through. Obviously, they're often working. Sometimes they'll come to me for an assessment, or a functional assessment, and then I would talk to them about what the treatment options are. So adults definitely can have tie releases done, but it just has to be a little bit more calculated and a lot more preparation than we do with babies, because they've had 20, 30 years, 40 years of dysfunction that they have to turn off and turn back on and things like that. So, it's it normally just stems from, it's the parent of the kids who I'm dealing with. And they're like, oh, but what about my tie? And then we talk through these symptoms and do a full functional assessment, and then I talk to the families or the people about what they can do from there. So, it really depends on what's going on with their jaw growth and palate development. And I've had a few parents who've gone and had a tie release done, and it's pretty cool.
So awesome. It's so interesting that you can really continue helping even adults with something that you think is only children and babies.
Totally.
Yes, that's so crazy. Well, thank you so much for joining us on the podcast. Before we finish up, is there anything else that you wanted to talk about or chat about?
I don't think so. I think we've covered a lot.
Also wanted to ask, where can everyone find you?
Well, I feel like hiding under a rock sometimes. No. Socials is usually the biggest thing. So Instagram, Facebook, they obviously have my details on there. And also, so I'm Midwife Tamika on Instagram. I'm Tamika Newman Lactation Consultant, I think, on Facebook, and website and things like that.
Okay, awesome. Well, I'll get everyone to take a look, and I'll put your information in the underneath part of the podcast. Thank you, everyone, for joining us today. May your days be balanced and your weeks be well.